All right, it is 7:33, so we will go ahead and get started. We do want to welcome everyone this evening. Just a few housekeeping items before we get started. If at all throughout the lecture you do have a question that you would like to ask, please be sure to put it in the Q&A at the bottom of your screen. Otherwise, if you just have comments or you'd like to chat back and forth with any of our panelists, there is a chat box as well. So we will be monitoring both the Q&A and the chat, and then we will follow up with any questions at the end of the lecture. In addition to this, I would like to introduce Dr. Caravella. He's our Chief Quality Officer and Pediatrician here at Allied Physicians Group. And I will pass it over to you. Thank you.
Good evening and welcome to Allied Physicians Group Continuing Medical Education Series for 2023. Tonight's topic is asthma. Asthma care is continuously evolving, and approaches to treatment need to account for individual differences in patients' genes, environments, and lifestyles. Dr. Kattan, our presenter for this evening, his participation in NIH-supported asthma consortium over the last 30 years has helped improve our understanding of asthma, its phenotypes, and developing interventions to improve asthma outcomes. Asthma continues to be one of the most common pediatric chronic diseases, and along with mental illness are number 1 and 2 in healthcare expenditures. Moving forward, in the ever-changing fiscal landscape of medical care, pediatrics and primary care will be the drivers of value-based and accountable care expenditures. In keeping with our asthma quality improvement initiative, tonight's speaker is Dr. Meyer Kattan. Tonight's lecture will review the updated asthma care guidelines from the National Asthma Education and Prevention Program and Global Initiative for Asthma, and indications also for recently approved biologic therapies for children. Tonight's speaker, Dr. Meyer Kattan, is a professor of pediatrics and director of the Pediatric Pulmonary Medicine at Columbia University Irving Medical Center, New York Presbyterian's Morgan Stanley Children's Hospital. Prior to Columbia, Dr. Kattan served as both chief of the Pediatric Pulmonary and Critical Care Division and director of Pediatric Pulmonary Fellowship Program at the Mount Sinai School of Medicine. Dr. Kattan is a graduate of McGill University's School of Medicine and completed residency and fellowship training at the Hospital for Sick Children in Toronto. Dr. Kattan conducts asthma-related clinical research, largely focused on urban populations. He is currently the principal investigator of childhood asthma in urban settings, New York Clinical Research Center. In addition, Dr. Kattan has studied alternative treatments for asthma, including Chinese herbal remedies and hypnosis. Please join me in welcoming Dr. Meyer Kattan.
Thank you, Dr. Caravella and the Allied Health Group for inviting me to give this lecture. I will, first of all, I have no disclosures. I've been funded, as some NIH-funded studies that use biologics, but I have no specific pharmaceutical support. The objectives of my talk are to review the asthma guidelines, the National Asthma Education and Prevention Program, which is the American group, and GINA, the Global Initiative for Asthma, which is mostly the European group. It's more of an international group, and talk about non-pharmacologic and pharmacologic approaches. I'll discuss some type 1 and type 2 inflammatory responses, and then I'll review the use of the biologics. First, let me start out by pointing out that asthma is a heterogeneous disease. Although there's a similar clinical presentation of asthma or phenotype that may be similar from patient to patient, the cellular or molecular pathways, or what we call endotypes, may differ. So to give you sort of a parallel to what that means, it's like if you take breast cancer, no more do we talk about sort of breast cancer, but we talk about the receptors on the breast cancer cell, and they may be similar to something on a colon cancer cell, and therefore the treatment for the two may be the same depending on the receptors on those cells. And that's what we mean by endotypes. And I think asthma is heading the same way. as you'll see from this talk. The majority of patients with severe asthma express the Th2 inflammatory phenotype, which is the allergic asthma phenotype or eosinophilic asthma. And most new biologics target this Th2 response, the T cell response. And however, that doesn't include every asthmatic. It's the majority, but I'd say about 15% of asthmatics are not of the sort of type 2 eosinophilic inflammation pathway. And they have some other pathways which are being explored and may need different therapy that we don't have yet. So just to give you a little background about Th1 and Th2 cell differentiation, you have allergens, viruses, air pollution, anything that may trigger a response. It's recognized by the antigen presenting cell, which is the dendritic cell, and it presents the antigen to an undifferentiated a T cell, which is the T cell is sort of the basis of cellular immunity. And this can differentiate once it's activated by the dendritic cell to differentiate into a Th1 cell, a Th17 cell, or a Th2 cell. I'll concentrate on the Th1 and Th2. The Th1 cell is more for a response to infection and results in neutrophilic inflammation. The Th2 cell is the eosinophilic inflammation, and so so the cellular immune system really differentiates. I'm looking at predominantly these two, and what determines allergy or this allergic sort of endotype is the ratio between Th2 and Th1. And people who have more Th2 cell, who are programmed to have more Th2 cells, are more allergic. And in fact, one of the ways that people are trying to prevent allergies is to try to divert the immune system early on to be more Th1 type than Th2 type. Sorry, excuse me. So the specific topics to be addressed in this focused update is that was just recently released in 2020 by the NAPP. They addressed exhaled nitric oxide, allergen mitigation, immunotherapy, inhaled corticosteroids, and the use of long-acting muscarinic antagonists. And I'll go through each of these and show you what's new in the guidelines. I'll start with the exhaled nitric oxide, fractional exhaled nitric oxide. This is an instrument that measures exhaled nitric oxide. You can see the little girl here is breathing into this mouthpiece, and this machine measures nitric oxide. And during inflammation, activated epithelial cells increase the production of nitric oxide. And so the more inflammation, eosinophilic inflammation there is, the higher the nitric oxide. So what is it used for? First of all, let me just, the addition of exhaled nitric oxide and can be an adjunct to the evaluation of the diagnosis of asthma for whom diagnosis is uncertain in children over 5 years. First of all, I think this instrument now is basically being used for children over 5 years. And that's one of the recommendations in the guideline. Could be used for the monitoring and management of asthma. What they don't think it should be used for is to be used in isolation like a pulmonary function test to predict future exacerbations or assess exacerbation severity, and it shouldn't be used to predict the future development of asthma. But it's hard, so basically it's an adjunct to therapy, to management. So in individuals for whom exhaled nitric oxide may be useful to monitor asthma are age 5 years and older with uncontrolled persistent asthma. Just see if the ENO is very high. It may mean that either they're not taking their medicine, because steroids should reduce. If someone's taking their inhaled steroids, the exhaled nitric oxide should go down. So it can be used as a assessment of adherence. Symptoms that might require additional therapy, it can be used in those patients and see if it remains high despite therapy. Then you can, it may be valuable. And if somebody's needing frequent assessments of asthma control over the year, it may be helpful, an adjunct to management. For allergen mitigation, the guidelines made a recommendation against the use of allergen mitigation as part of routine asthma management in individuals who are not sensitized to or have symptoms related to indoor allergens. So just using it on everybody wholesale is not recommended. And they think that multi-component allergic specific mitigation intervention in individuals who have symptoms related to exposure to identified indoor allergens. And what they mean by multi-component allergen mitigation is to address more than one thing, because usually it's not simply one allergen or one exposure or irritant that triggers asthma. It's usually a combination of factors. Integrated pest management has been used. It's in some studies it seems to work, and some other studies it may not work. I know that we did a study in children who were cockroach sensitive and were cockroach and were exposed. And when we did some integrated pest management and allergen, a whole program of environmental control, we did have an effect. But again, this was in a group who had a high exposure and high allergies to a cockroach. Use of pillow and mattress covers should be part of a multi-component intervention. Mattress and pillow covers do reduce exposure to dust mites, but again, thinking that nobody's exposed only to one allergen or irritant by itself would not make much difference. So, there's certain single component mitigation measures that have been taken. I just comment on a few of those. If people are going to have an air purifier, I recommend that they use a HEPA filter. The HEPA filters can reduce allergens to pets, can reduce the irritant particles, the PM 2.5 from cigarette smoke or particulate matter from gas stoves. I don't usually recommend carpet removal because I think they can be controlled without it. But if they don't have a carpet, I don't recommend that they get one either. The pillow and mattress covers, I think, are a good idea. And if there are pests like mice and rodents and cockroach, it's good to get integrated pest management. I know that New York City has some programs where they will provide integrated pest management in the 5 boroughs. A lot of people come to me and say that they had their house assessed for molds. Everybody's house has molds. All you have to do is go into your bathroom and you have mold. Any mold exists where there's wetness. And What you're really looking for are, leaks, the paint, uh, leaks behind the walls, or sometimes it's more obvious than that. And what needs to be done is, whether you don't need to measure the amount of mold, because we don't know what the amount of mold is and how it relates to symptoms, but we know that mold is a irritant and an allergen, and associated with increased respiratory infections. And basically, if there are leaks, those have to be dealt with. It means not just painting over the wall, it means tearing down the wall, changing the sheetrock. It's a big deal. Unfortunately, people are spending their money on assessing the mold instead of fixing the mold. Pet removal, I don't recommend unless, the asthma is not controllable. In terms of immunotherapy or allergy, skin test, allergy shots, SCID is subcutaneous immunotherapy. They recommend it in individuals whose asthma is not controlled, with the usual pharmacologic means. And they did not recommend, given the current evidence, on sublingual immunotherapy. Now to the pharmacologic management, what they the big changes are, basically steroids were recommended as the first line therapy. Inhaled steroids as the first line therapy for people who were symptomatic more than twice a week, needing albuterol more than twice a week, or having more frequent symptoms, nighttime symptoms. The change is that one of the changes that here they recommend in younger children a short course of daily inhaled corticosteroids at the onset of respiratory infections with as needed short-acting beta agonists for quick relief, compared to just using the short-acting beta agonists for quick relief. That's in the younger children. The other other recommendation is that daily low-dose inhaled corticosteroids and as needed the beta agonist, or as needed inhaled corticosteroids and short-acting beta agonists used concomitantly. So basically what that's saying is that you can use a combination of the inhaled corticosteroid and short-acting beta agonist as one inhaler, and use it both just as needed. So it would mean using an inhaled steroid and long or a short-acting beta agonist together, 4 times a day, if needed. And that's based partly on the fact that they assume that a lot of people who are on daily medicine are not using their inhaler anyway, and that they can use it this way. So basically, it's a little boost in the inhaled steroid in addition to giving the beta agonist. They are against a short-term increase in inhaled corticosteroids for increased symptoms or decreased peak flow in children. And the next is that using inhaled corticosteroid and formoterol in a single inhaler can be used as both daily controller therapy and reliever therapy in those that are over 4 years of age. Now, why formoterol specifically is because formoterol acts a little quicker than some of the longer acting beta agonists. And if you're using it as for relief, you want more immediate relief. And you can use the other recommendation is that you can, in children over 12 and adolescents and adults, you can use as both daily controller and reliever therapy. So it's the same in the 4 and the 12-year-old, anybody over 4. So I'll just go through the steps, which you're familiar with these. But basically, I don't want you to go through this whole thing, But as you know, the people who have intermittent symptoms or short-acting beta agonists may be enough. But as I said, the new change, as you can see in the red box, is that you could also add a short course of daily inhaled corticosteroid. And that's as you get more symptomatic, and the more you add daily inhaled corticosteroids, and as you increase, as severity increases, you can increase the dose of inhaled corticosteroid. And the difference now is, instead of going on too high a dose of, well, this is in the age 0 to 4. Okay, sorry, let me just go back. But you assess the control and by checking adherence, making sure they're taking their inhaler properly, reassess them in 4 and 6 weeks after starting it. And if they've been well for 3 months, then you can step down the therapy. Now, but this is in the 0 to 4 year age group that I just showed you. But I'm going to give you 2 case reports. You have a 3-year-old with eczema, lingering cough, and sometimes wheezes with colds. And there's a family history of asthma. And you have a 3-year-old with 2 severe episodes of wheezing last fall and 1 episode of wheezing this fall, and no family history of allergies or asthma. As I started my talk initially, I said that, there's phenotypes and endotypes. Now, these 2 probably don't have the same endotype. The top one, the first case, looks a little more allergic, and the second case, it doesn't seem so allergic. So will they respond? So that's where the guidelines sometimes falter. So, the guidelines sort of make you think of everybody as the same, but these 2 children, as you can see, are not the same. And I bet you that the 3-year-old with the eczema and the lingering cough with colds probably will respond better to the inhaled corticosteroid than the other one, who has intermittent wheezing as well between episodes. And for that second scenario, some people give oral steroids once or twice a year, whatever, but there are many studies that show that it's very hard to treat these severe episodes or prevent these severe episodes. So I just wanted to show you, but I certainly would try giving the inhaled steroids, but the outcome may not be the same. So who should get intermittent steroids according to these new guidelines is more than 3 episodes in a lifetime of wheezing triggered by respiratory tract infection, or greater than 2 episodes in the past year and are asymptomatic between infections. So I just showed you 2 cases, which I think that this recommendation, although I would follow it, probably won't work for both cases. It'll work for one of them and not the other. And basically it's giving 7 to 10 days of inhaled daily corticosteroids and a short-acting beta agonist. And the first sign, and you would start the inhaled corticosteroid at the first sign of a respiratory infection. And the main potential is the reduction in exacerbations requiring systemic steroids. And again, that's based on studies where children were allergic. So whether it works in people who are not allergic is another question. And in terms of the downside in the young kids of inhaled corticosteroids, one study showed a 5% lower gain in height and weight with fluticasone up to twice daily, up to 10 days versus placebo. And another study did not show an effect on linear growth. So this intermittent use of steroids is questionable. It's still possible that there's an effect on height. Now, once we get to the older age group, again, it's the same thing. You said step one, which is using the as needed short-acting beta agonist, and increasing the dose of inhaled corticosteroid or stepping up the therapy. Now, in the red box, I just want to mention or highlight the sort of changes in the recommendation. And they're sort of recommending that instead of going up on too high a dose of steroids, before you do that, you should try the combination staying on the low dose and using the long-acting beta agonists. So like Symbicort, instead of going up to a higher dose of the inhaled steroid. And I think that's the general consensus these days, rather than going to much higher doses of inhaled steroids, because the higher the dose of inhaled steroids, the more likely it is to have an effect on height. And I just want to say, both for the very young kids and this age group, the alternative therapies that they mention are the leukotriene antagonists, which is montelukast. I just keep in mind that montelukast has been marketed as good for allergies, and it's good for asthma. It's not the best drug for either. There are better drugs for allergies and there are better drugs for asthma. And in addition, there's a black box warning about neurobehavioral issues, including risk of suicide. So the patients, if you're going to use it, you should tell the patients about that black box warning. I tend not to use it if I don't have to. In terms of the age 12 and up, it's really the same thing, except this, and especially the GINA guidelines, are very keen on using PR, even in sort of mild asthmatics, PRN, inhaled corticosteroid, and short-acting beta agonist, or using the long-acting beta agonist on an as-needed basis. And so what happens there is that when the patient is sick, they're going to be getting a higher dose of inhaled steroid in addition to a long-acting beta agonist. And you can give that even though it's long-acting, you can give it up to every 6 hours. So that's what's called smart therapy, okay? And the one good thing about the GINA guidelines is they're updated all the time. And their most recent update is not longer smart therapy, because when I gave the title, it was still smart therapy. Now it's not smart therapy. They took out the S. And the reason S was for Symbicort, and they didn't want to do it that way. It's just using a single inhaler, because so it's now MART therapy. And basically you went from using daily Symbicort and as needed, and then using it more as needed, to just using it and then adding sort of a beta agonist, just using it daily Symbicort and as needed as well. So instead of using a short-acting beta agonist, you're using the long-acting beta agonist, the Symbicort, as needed as well. So it eliminates having 2 inhalers, which increases compliance. So who should get this intermittent inhaled corticosteroids? It's mild persistent asthma, where it's not on therapy, and temporary use of inhaled corticosteroid in response to worsening asthma in an individual who's not taking inhaled corticosteroid controlled therapy. And they may not be taking it because either you didn't prescribe it or you did prescribe it and they're not taking it anyway. And you can give 2 to 4 puffs of albuterol followed by beclomethasone or any other inhaled corticosteroid. Sorry, so actually, this just sort of emphasizes the use of the low dose inhaled corticosteroid and formoterol before raising the dose of inhaled corticosteroid. Again, this I showed you that for the 5-year-olds, 5 and above, but I'm showing you this now for the 12-year-olds as well. Now, the other recommendation that the guidelines made is about long-acting muscarinic antagonists, and these antagonists act on the cholinergic system and could result in bronchodilation. The recommendation is against adding these LAMAs to inhaled corticosteroid before adding the long-acting beta agonist ICS combination. And adding the LAMA to inhaled corticosteroids compared to continuing the same dose of inhaled corticosteroid alone, where the long-acting beta agonist is not tolerated, which is in too many patients. Or adding LAMA to inhaled corticosteroid LABA compared to continuing the same dose of ICS LABA. So there's a group, I think that I would reserve it for people who are not responding well to the inhaled LAMA, ICS long-acting beta agonist combination. So here it is in the chart, again, leaving it, I'm using it here for the highest step. I would go here before I would use it on the lower steps. As I said, the recommendation is that some people maybe not be tolerating long-acting beta agonists, but I don't see that many people in this category, in these two categories. Let me go on now to the biologics. But before you do that, you think that their asthma, and it's for patients that are not controlled by these recommendations that I just reviewed. First, you have to make sure they have the proper inhalation technique, that adherence is good. You can check that by pharmacy refills. And as I alluded to earlier, you can use exhaled nitric oxide as sometimes helping you see if they're adherent or not. And both the parent and the child have to be willing to receive biweekly or bi-monthly injections. And you should confirm the diagnosis, because some children who are poorly controlled or unresponsive to therapy have what we call exercise-induced laryngeal obstruction or vocal cord dysfunction, which can mimic asthma. And some may not even have anything that resembles asthma, but can have ciliary dyskinesia or cystic fibrosis or gastroesophageal reflux. I don't want to put too much emphasis on GERD, but it should be thought of. I think that that's less of a problem. Usually when people go to the ENT before they see a pulmonologist, they do laryngoscopy and see that the larynx is a little red and say that it's probably GERD. But if you're coughing chronically, your larynx is going to be red, and it doesn't mean that there's reflux. And in fact, there are studies that show there's absolutely no relationship with what the larynx looks like and respiratory disease and gastroesophageal reflux. So what is a biologic therapy? It's a medication made from living animals, plants, or cells instead of going through a chemical process. They're monoclonal antibodies, or antibodies produced by an identical immune cell that are clones of a parent cell. And all current biologic therapies for asthma are humanized monoclonal antibodies. That means they take the protein of the and they make it more. They make some changes in that make it resemble more the human antibody. And there's certain biomarkers that you should look for before you use it. And so it can help you decide whether a biomarker is helpful. You can look at blood eosinophils, the exhaled nitric oxide, and allergy testing, prick testing, and total and specific IgE. So just to go back to this allergen viruses pollution, sending off the differentiation of the undifferentiated T cell. And if there's certain cytokines, it will drive the differentiation to the Th2 cell. You have more eosinophils. And if you have IL-4, IL-13, which are other cytokines, it stimulates the B cell to produce IgE antibodies. So again, so what these biologics are directed mostly at these cytokines to try to block these cytokines or their receptors, or to block IgE. So I'll just go through some. So let's take omalizumab, which is an anti-IgE monoclonal antibody. Just to go through this quickly, the B cell results after it's stimulated by the T cell, switches to to produce IgE antibodies, the plasma cell to produce IgE antibodies. And these antibodies can hook onto the Fc receptor. And when that happens, and these receptors are on the mast cell, or the basophil, or the eosinophil, when these are when that happens, you get release of soluble mediators that result in allergic inflammation. And what omalizumab does is binds to the free IgE. It decreases the expression of the high affinity receptors and decreases mediator release, and that way prevents the exacerbation. Now, omalizumab has been available since I think 2006 or something like that. So there's a long history of use. It seems to be safe and very effective. Here's a study that we did with looking at days of symptoms over a 2-week period, averaged over a year. And this is the placebo group in blue. This is the treated group in orange. And what you can see is that both groups started out before treatment with 5 symptom days per 2 weeks on average over the year, which means almost, quite symptomatic quite often. So it was a pretty moderate to severe group. And there was a statistical difference, but as you can see, even though it's a statistical difference, it's not a huge difference. And it may not be worth the price of the drug, which is close to $40,000. But what we also found when we looked at exacerbations, and this is looking through the year, again, the blue is the placebo group, the orange is the omalizumab group. And not too surprising is there's a spring peak in exacerbations related to allergens, and a bigger peak, which you're all familiar with, is the viral induced September exacerbations, the fall exacerbations. But in the group that received omalizumab, these 2 peaks were wiped out. But since the study wasn't exactly designed to look at that, we did another study where we gave them treatment for starting in August for 4 months, which obviously reduces the price of the treatment. And you can see that we reduced exacerbation. We cut exacerbations in half. So that's a group to think about that might be eligible for Xolair is allergic individuals who have fall exacerbations. And this drug is approved for children 6 and over. So, as I said, it's for 6 years and over, moderate to severe persistent allergic asthma. They're not well controlled on inhaled corticosteroids, and they have positive allergens, skin tests or IgE, and they have an elevated serum IgE. Now, I'm just wanted to show you, this is the dosing chart, but the dose of omalizumab is based both on body weight and IgE. And unfortunately, a lot of the severe asthmatics have a very high IgE and are overweight. And they won't meet the dosing criteria because the volume becomes too high. So there are some limitations on its use. And basically it's based on the combination of the weight, as I said, and the IgE level. And if you exceed that, then it becomes a problem. The dose can be given every 2 weeks or every 4 weeks, but even in some of the higher doses, they'll still need 2 injections because the volume would be too high if you gave it all in one arm. Now, why would a allergy drug affect viral induced asthma? And it turns out that omalizumab, by decreasing the IgE and decreasing the expression of the receptor on the dendritic cells, results in increased interferon activity and decreased virus-induced exacerbation. So basically, it somehow also affects the interferon response and improves it. Okay, the next drug that we have that's approved, I'm only talking about the approved drugs in children. So we have omalizumab, which I mentioned. We have mepolizumab, which is heavily advertised in the column. It's an anti-IL-5. So there are IL-5s on receptor, which is a cytokine in allergic individuals, and it's released by eosinophils. What mepolizumab does is bind to the IL-5 cytokine, and it prevents the interaction with the IL-5 receptor, and therefore you don't get, and then it reduces the production and survival of blood eosinophils. And there's less cytokine release, which produces inflammation. Excuse me, I'm just going to drink some water here. Dupilumab, which is Dupixent, also heavily advertised, also approved for children 6 and over, is an anti-IL-4 receptor monoclonal antibody. So there are IL-4 receptors on the eosinophil, and what it does, it blocks both IL-4 and IL-13, which are cytokines, from binding, and it interferes with differentiation of the Th2 cells and the B cells. And again, this has been an extremely useful drug for eczema in even 2-year-olds. It's approved for 6 and over, just like mepolizumab and omalizumab. So if a child has eczema, severe eczema, and asthma, this would be a good choice of medication. Benralizumab is an anti-IL-5 receptor. Again, it acts on the receptor, and it depletes the eosinophils and basophils by blocking IL-5 from binding to its receptor. This is approved for 12 and over. And the last one, which I don't know, certainly they're coming around to us, the pharmaceutical companies, but and I think it's also been advertised on TV lately, is tezepelumab, which blocks thymotropic lymphopoietin, and it reduces a broad spectrum of the downstream biomarkers and cytokines that I've showed you, the IL-5, the IL-13, and the IgE as well. So, and it's been shown to reduce exacerbations in patients without eosinophilia, demonstrating a new mechanism of action and benefit for those without qualifying options previously. Because the other drugs I showed you, and as you'll see, depend on having a certain level of eosinophils before they are effective. And this is approved, as I said, for children 12 and over. So here, if we compare them, omalizumab, greater than 6 years of age, and it's subcutaneous. It's given every 2 to 4 weeks, depending on the dose that you need. Mepolizumab is greater than 6 years, and you need peripheral eosinophils of 150 or more. All these medications that are attacking the eosinophils did not work when the eosinophil level in people who had low eosinophil levels. So mepolizumab is every 4 weeks. So that's an advantage. One of the it's not that common, but is a significant side effect is conjunctivitis, which can be treated. And benralizumab, I just mentioned, that's for greater than 12 years or over. You need a higher eosinophil count. And it's every 4 weeks for the first 3 doses, and then every 8 weeks. And dupilumab, which is Dupixent, is for 6 years. Again, like mepolizumab, has peripheral eosinophil count of 150 is a minimum, and that's given every 2 weeks. So, but if a child has severe eczema, I would prefer this drug, the dupilumab. The advantage of mepolizumab, it's every month instead of every 2 weeks. They both work extremely well. So the biologics have good safety and efficacy profiles. The cost is high, as I said, $30,000 to $40,000 a year, and I would reserve it for the minority of severe asthmatics. And perhaps one can reduce the cost by using omalizumab in that certain group of patients that I mentioned to you earlier who have the fall exacerbations. Okay, so now I have time for some questions, and I'd be happy to answer them. Where should I look for questions?
I can read them out to you. Thank you so much for your presentation. We appreciate it. So the first one we have is, when are ICS medications considered, in quote, fully effective?
Okay. I've seen people who say that within a week, there's a dramatic difference. I think that the general recommendation, it takes 2 or 3 weeks to make sure that it's working. What I do is I tell patients who I'm starting it on, if the child has been coughing every day and has exercise-induced symptoms or whatever, I say give it for 2 months, and if you see it, and give it whether it's working or not, and I'll see them in 6 to 8 weeks and decide whether it's working. They should be able to tell within 6 to 8 weeks if the daily symptoms resolve. It's more difficult to tell in people who can go 6 to 8 weeks without a problem, because then it might just be a coincidence that they're better.
Okay, thank you. Next, we had a little bit of a discussion back and forth about Symbicort, but it looks like the group answered the questions. After that, the next question we have was, and I apologize if I pronounce any of the medications wrong, but in your study comparing omalizumab versus placebo, did you see a significant decrease in hospitalization, ER, or urgent care utilization in the treated group?
Yeah, well, as I showed you, there was certainly an increase in exacerbations. I showed you that slide. We wiped out the exacerbations, and that's why we tried the second study, which was aimed at reducing exacerbations. So it definitely reduces exacerbations. Hospitalizations are not a frequent event, and in the study, we are not powered to look at that. So there were less exacerbations, but it's not going to be statistically different.
Okay, next we have, with the recent FDA approval of the monoclonal antibody nirsevimab, brand name, I'm sorry, it's Beyfortus, would you comment on RSV prevention and how the one compares to the other? And then in parentheses, they said synergies.
Sorry, Those are for the prevention of RSV, not for the not for the treatment of asthma. Unless I'm misunderstanding the question.
No, correct. So it wasn't for the prevention of asthma, but we figured we had a captive person here. So, we've got some prevention for RSV, certainly a wheezing illness that none of this treatment is going to be helpful for. But did you or have you had any, do you have an opinion on the effectivity of the newly approved, there's a bit of a bad, I can't even say it, Beyfortus and
Yeah.
Synergis?
Yeah. So, most of the exacerbations are related to viral infections. The most common being rhinoenterovirus, which we don't have anything, which we can't prevent. The RSV also causes wheezing illnesses, as we all know. So I think preventing RSV is important, and I think that will reduce exacerbations in asthmatics. And just like influenza, right? People who are vaccinated are less likely to get influenza and less likely to be just another virus that induces wheezing. So if we can prevent certain viral infections, we're going to reduce or we're going to improve control and reduce exacerbations.
Okay, next up we have currently only formoterol is the only quick release long acting beta agonist, starting within 3 minutes of inhalation of the powdered form and reaching 80% of peak effect within 15 minutes, available in the United States. Are there any others in the pipeline for FDA approval?
Not that I know, but just let me say something about that. They're using it for quick relief now, and it's the marketing that's been quite effective by saying that it acts much quicker than the other. And you're talking acting within a few minutes to acting maybe within 20 minutes. The problem that we have, right, is the insurance companies. You can prescribe Symbicort and they tell you they don't approve it. You have to use Dulera. So you're stuck. So you're going to give Dulera. So, if it doesn't seem to be working well enough and they need it so quickly, again, it's usually, most of the kids, it's not coming on, 1 second they're well and the next second they're not. They're coughing and they're starting to have some symptoms. What you would do is increase the dose of the ICS LABA, and as the guidelines recommended, to use it instead of twice a day, use it twice a day and as needed every 6 hours. So I'm not sure that all of it is under our control and that makes a huge difference. If somebody would like to follow up with a question about what I said, I think it's an important question.
All right, so we'll see if anyone else comments in the chat. We do have a couple other questions in the meantime. So we do have, thank you so much for the presentation. Could you review how the nitric oxide mechanism works with regard to asthma exacerbation?
It's just when there's more inflammation, the epithelial cells of the lung end up producing more nitric oxide. So the more inflammation there is, the higher the NO level.
So next we have Dulera is formoterol. Oftentimes insurance wants us to use Advair. Can we use that as smart therapy?
Yeah. I think I just answered the question about the insurance companies. If that person thinks I didn't answer it, then I'll answer it. But again, you have Dulera, you have Advair, and you have Symbicort are the ones that are most commonly approved. Well, right now, all I know, my experience is they don't approve anything and you need prior authorization, which is really a pain.
All right. With asthma and social determinants of health, do you have any recommendations to help populations who might have difficulty getting their medications or getting any resources that they may need?
Yeah, I think that, obviously my whole career has been dealing with populations that are underserved and have psychosocial issues. And I think the most important thing is having good access to care. In our research studies, I can tell you that our patients who are on the placebos do extremely well. Why is that? It's because they get follow-up care. They have 24-hour access to our research assistants who are not even doctors or nurses, and who so instead of going to a clinic where it takes 30 rings to have your call answered, and you don't have to press 1, 2, and 3 up to 7 or whatever, and you get hung up on, and you get an appointment 3 months later or whatever, you can at least speak to somebody and have good care, and you have monitoring and education. So these are the types of access, both education, accessibility, I think, that are important to improve outcomes. And in fact, we did a study. One of our first studies was using an asthma counselor, meeting with them every 2 months, who would, we assessed what the risk was for those patients, whether it was access to care, whether it was smoking. We had different modules. And this asthma counselor was not a nurse, it was a social worker. And we figured we could teach a social worker how to use an inhaler better than we could teach a nurse, to address social issues. And basically what we found is that without a doctor, that meeting with the social worker and having the social worker trained to assess certain types of issues. For example, if the patient she spoke to the patient, and the patient said, I went to the emergency room. Why'd you go to the emergency room? I ran out of medications. She would try to promote good behavior as opposed, and discourage bad behavior. You should make sure you get your medications refilled. If you have a problem, let us know. So addressing the social issues, this proved that, and we had a wonderful outcome. We reduced symptoms without a doctor intervention, and they were also told what to tell the doctor, because if they don't tell the doctor what the problem is of concern, they're not going to get the right treatment. So if they tell, the social worker was, cued into saying, look, are they taking gym and this and that? And if they say, no, they don't take gym, because they're wheezing when they're running around, we said, tell your doctor that that's what's happening. Because if they don't, if you underestimate or you don't get the right symptoms, you're not going to give the right treatment.
Thank you for your thorough explanation on that. We appreciate it. Next, we have, how would you advise patients on SMART therapy with either, again, I apologize with this pronunciation, budesonide for Motorol or mometasone for Motorol in an acute event, i.e. red zone of an asthma action plan?
Oh,
So I'll actually clarify the question just a little bit better. So you have your patient on single inhaler therapy, either Dulera, Symbicort, generics of either one, having an acute event, right? How would you advise them via, for example, an asthma action plan in that red zone? They're in trouble. What would you do? Or how do you advise them? And they only have that single inhale.
okay. So that advice doesn't go in the red zone. That advice goes as the quick relief, right? So what the first part is, take, the green zone is take your medication twice a day. The relief is give that medication every 6 hours.
Right, correct. So I guess the question I have here is the patient has the single inhaler and they're having an event, and they took their 2 puffs of Symbicort, and 15 minutes later, 20 minutes later, they're not having any relief.
Right.
So in the past, when we just used albuterol, we would use 2 puffs roughly every 10 minutes. And if you go 6 puffs, you're in 30 minutes and you're not any better, we're kind of recommending them to go to urgent care, call ER, etc. So but when we have a person on a single inhaler and that's all they have, how do you advise them? Is it an every 15-minute, or it didn't work for you? What do you do?
So, although that's what people advise, I basically tell them if the second step is not working and lasting at least 4 hours, you should call your doctor or get help. I mean, in the emergency, I guess you could give a short-acting beta agonist and see if that helps. Um, give same as what it was before. Give the 2 puffs every 10 minutes. But basically, those people have to go to the doctor or go to the emergency room, or at least get some advice. I don't, although in our studies, by the way, we do prescribe short course steroids. We give them at home, prednisone, and tell them that call us if you're going to use it. We give them 1 course as just to have on hand. In my practice, I don't do that. I tell them if they're going to need a steroid, if they're not responding, they should call.
Got you. Okay. For our attendees, do we have any other questions for Dr. Kattan? Dr. Kattan, we'd like to thank you very much. I know you're not necessarily up to feeling well today, when we really do appreciate that you were able to pull through this. I know your voice, you're going to need to take a rest to get your voice back, of course. For our group, we'd like to conclude this evening. I just would like to remind you, we have another meeting and lecture on August 15th. It will be Autoimmune Inflammatory Diseases by Dr. Ganjuli. And we hope to see you all. Just want to remind you for the attendees that you'll be getting post-lecture evaluations, and please fill those out and get them back so that you can get your CME for this evening. And one last time, Dr. Kattan, thank you so much. We really appreciate your insight and information. It was wonderful.
Okay, well, thank you for having me. Have a good night.
You too.
Bye-bye.
And good night, everyone.